called as your Clostridium perfringens. So three very important organisms. We'll see how we get it and all that as a part of preformed toxins. So preformed toxins with Staph aureus, Bacillus aureus, Clostridium perfringens, organism producing the toxin, increasing cyclic AMP, drawing water, secreted diarrhea. That is seen with enterotoxigenic E. coli, and that is also seen with Vibrio cholerae. The only organism that invades the small bowel, is your Salmonella typhi. But Salmonella typhi doesn't produce diarrhea, so we don't have to discuss that. That is fever and abdominal pain, fever which will supplement, that's typhoid. Typhoid we are not discussing here. Okay. So when you talk of the small bowel pathology, what things come to your mind? When you talk of small bowel pathology, osmotic diarrhea, secreted diarrhea come to your mind. Here we are not discussing anything osmotic. Secreted diarrhea is due to toxins. The two main toxins are enterotoxigenic E. coli and Vibrio cholerae. Enterotoxigenic E. coli is the most common cause of secreted diarrhea. It is the most common cause. Invades the small bowel is your Salmonella typhi. But Salmonella typhi doesn't produce diarrhea, so we don't have to discuss that. That is fever and abdominal pain, fever which will supplement, that's typhoid. Typhoid we are not discussing here. Okay. So when you talk of the small bowel pathology, what things come to your mind? When you talk of small bowel pathology, osmotic diarrhea, secreted diarrhea come to your mind. Here we are not discussing anything osmotic. Secreted diarrhea is due to toxins. The two main toxins are enterotoxigenic E. coli and Vibrio cholerae. Enterotoxigenic E. coli is the most common cause of secreted diarrhea. It is the most common cause for traveler's diarrhea, and it produces the toxin which increases cyclic AMP and all that. Then we are having food poisoning relating to preformed toxins due to Staph aureus, Bacillus aureus, Clostridium perfringens. Then the only organism that invades the small intestine is Salmonella typhi, but that doesn't produce diarrhea. It produces more of fever, abdominal pain. That is your typhoid, which we are not talking of here. So this is the essential backdrop on top of which we are discussing. Now there are certain protozoan parasites which also involve the small bowel. When you think of protozoan parasites involving the small bowel, then of course naturally it is your CMG that comes to your mind. C stands for Cryptosporidium and Cyclospora, M stands for Microsporidium, and G stands for Giardia lamblia. But they all produce diarrhea lasting for more than 1 week. So it's not that common here. Cryptosporidium and Cyclospora, M is Microsporidium, and G is Giardia lamblia. This is a general approach to infectious small bowel diarrhea. Correct? Now, when I talk of a large bowel diarrhea, so large bowel diarrhea with infections, when I'm talking of what comes to my mind. So I told you the pattern of diarrhea. Along with that, the patient will also have fever and abdominal pain because it is involving the large bowel. You will have fever, abdominal pain. Small bowel diarrhea, you can have some vague abdominal discomfort, but no proper abdominal pain, and you'll be having a lot of WBCs in stool. So fever, abdominal pain, WBCs in stool. Large bowel diarrhea is due to invasive organisms. Correct? It is due to invasive organisms. When you think of that invasive organism, the first organism that comes to your mind is Shigella. So most common cause for large bowel diarrhea, invasive organism. Shigella has toxins, but toxins have nothing to do with diarrhea. It is a large bowel diarrhea due to Shigellosis, and the organism load required is only 10 to the power of 2. Just 100 organisms are required because it is so invasive. Then after Shigella, Campylobacter. Okay, after Shigella, Campylobacter. Then your non-typhoid salmonellosis. Yes, non-typhoid salmonellosis. Correct. Then your enteroinvasive E. coli, EIEC. Then your Vibrio parahemolyticus. So these are common organisms. So enteroinvasive E. coli, Vibrio parahemolyticus, non-typhoid salmonella, Campylobacter, but most important is Shigella. And as far as parasites are concerned, protozoans are concerned, Endemica histolytica. Okay, Endemica histolytica. Right? And CMV can involve small bowel and large bowel. There are different opinions. Some people think small bowel is common, but often we are seeing more of large bowel involvement in CMV. So CMV in immunocompromised patient renal transplant recipient can involve both. In case somebody is asking you more, you say CMV colitis is slightly more. So these are the invasive organisms. And on top of this, in large bowel, always we have a separate disease topic to discuss. That is Clostridium difficile enterocolitis. It is not just a colitis as you can see here. It is enterocolitis, which means that small intestine and large intestine are involved. But diarrhea pattern is mostly a large intestinal pattern. So Clostridium difficile enterocolitis is a separate topic to discuss. Yersinia enterocolitis. Yersinia is another organism which again can involve the small and the large intestine. It produces actually speaking ileocolitis. So Yersinia is ileocolitis. So these are the other organisms. So very importantly, if you ask me virus, norovirus in adult, rotavirus in children, toxin means enterotoxigenic E. coli and your Vibrio cholerae. Preformed toxin means Staph aureus, Bacillus aureus, and Clostridium perfringens. They are all in the small bowel. When it comes into the large bowel, invasive organism means it is Salmonella, which is Salmonella, non-typhoid Salmonella, with Campylobacter, and the most common one, which is Shigella dysentery, which is Shigellosis is what we call Shigella dysentery, flexneri, and all that. Then we have Shigella flexneri is the one that generally produces this more. Okay. Then we have enteroinvasive E. coli, Vibrio parahemolyticus, and this Endemica histolytica. We have these Clostridium difficile enterocolitis and Yersinia enterocolitis, which is a combination of two. That is small intestine and large intestine, which we have specific points to study. So this is on the whole basic background that you have to know. From where you can get any kind of integration question. I'm not going into this table per se because it is not possible for anybody to study this table. If you know which disease comes in which pocket, you can very easily see. I'll just show you an example. Take Shigella now. So when I'm taking Shigella, abdominal pain, will you mark it as right or wrong? Yes, definitely, because it is large intestine. Fever, yes, large intestine. Inflammation, yes, large intestine. Vomiting, nausea are very non-specific symptoms. So you can't rely on that by any means. Heme positive stool, yes. Bloody stool, yes. This is how you take it. Okay, so I think it's very clear and it's, I think, self-explanatory. Now we'll see the common one-liner questions that have come from here for the exam. That's why we're studying this. Most common cause of diarrhea in adults bar children. Most common cause of diarrhea in adults is norovirus. Most common cause of diarrhea in children is rotavirus. Severe ileitis resembling appendicitis. This organism produces ileocolitis. So because of severe ileitis, they can have abdominal pain which looks like appendicitis, and because of colitis, they can have large intestinal symptoms. This is called the famous Yersinia enterocolitis. Yersinia enterocolitis is a common question for the exam because it has abdominal pain mimicking appendicitis. So please keep in mind. Trigger for GBS is Campylobacter jejuni. Campylobacter jejuni, very important points to remember. One, it is an invasive large bowel organism. It can be a risk factor for IBD. One thing, it is a trigger for GBS. Second thing, and it is associated with immune proliferative small intestinal lymphoma. Okay, what we call as IPSID, immune proliferative small intestinal disease. or small intestinal lymphoma, so immune proliferative small intestinal disease. So IPSID association of Campylobacter has been asked. Severe inflammatory diarrhea affecting all the 4 layers can be seen with everything, but the best answer is shigellosis caused by Shigella flexneri. Staph, Bacillus cereus, and Clostridium perfringens are 3 very important organisms because they act by producing preformed toxins, and preformed toxins are having nothing to do with the large intestine. It has got to do only with the small intestine. Okay, hope everything is clear. Please study this. You'll get a lot of value with respect to both micro and medicine. We go to preformed toxin of Staph aureus. Now, Staph aureus preformed toxin. Point number 1 is incubation period is less than 6 hours. Point number 2, you get it from all kinds of food, but the most important food is custard. Okay, pork, canned meat, everything can be there, but I think custard is the single best answer. Third, what is the most prominent symptom in these patients is vomiting. Okay, it is not anything else. Vomiting with some cramps. That's it. Fever is not there. Hypotension is not there. There is no role for antibiotics. It is self-limiting. So nothing to actually study. Otherwise, only major point is vomiting, and this vomiting is mediated by 5-HT, acting on which receptor? 5-HT3 receptor. So it produces this heat-stable enterotoxin. This heat-stable enterotoxin is a preformed toxin. Again, most of the enterotoxins I think you know are heat-labile. Only few things are heat-stable. Classically, we say Bacillus cereus is heat-stable. We say Staph is heat-stable. We say E. coli has a heat-stable toxin. It has labile and stable. It has heat-stable toxin. Yersinia has a heat-stable toxin. Those are things I am aware of. All the others are generally heat-labile. Now we come to the next player, who is Bacillus cereus. Bacillus cereus actually is very important because you can get 2 kinds of questions. One question from Bacillus cereus is the one where the incubation period is 1 to 6 hours, and second one where the incubation period is 6 to 12 hours. So 1 to 6 hours and 6 to 12 hours. This 1 to 6 is formed by the heat-stable toxin. Heat-stable toxin, and it is a preformed toxin. Okay, preformed toxin. This 6 to 12 hours is by the heat-labile toxin. Heat-labile toxin, and it is not a preformed toxin. It is a formed toxin. Okay, formed toxin. This preformed toxin is characterized by vomiting. That is why it is called as the vomiting predominant Bacillus cereus food poisoning. That is characterized by diarrhea. So this is the diarrhea predominant one, where there is increase in cyclic AMP. This is invariably associated with fried rice. Okay, invariably associated with poorly cooked or undercooked fried rice, and this is almost always associated with meat. Okay, meat. And sometimes with pudding also. Pudding is also sometimes described. So once again, let us go back and see. Uncooked fried rice, preformed enterotoxin, 6 hour.
ഹലോ കഴിക്കാൻ വരുന്നില്ല. അതല്ല, മറ്റേ കത്തിയല്ല മറ്റേ കിച്ചന്റെ താക്കോലേടിയുള്ള അതന്ന് അവരിവിടെ തിരിച്ചു വെച്ചിട്ടില്ലേ? 2 ഇയേഴ്സ് ഇവിടെ കാണുന്നില്ലടാ. എന്റെ കീ ചെയിനും കാണുന്നില്ലല്ലോ. അല്ല, കീ ചെയിൻ അല്ല, ബൈസൈക്കിൾ ലോക്ക്. ആരെങ്കിലും കൊണ്ടുപോയോ? തുടങ്ങിയോ? എനിക്ക് ഫുഡ് കഴിക്കാൻ മോടില്ല. ഈ കഴിച്ചോ? ഓക്കെ, ബൈ.
Is the emetic type or the vomiting type. 6 to 12 hours with the diarrhea is the diarrhea type. So one is heat stable, second one is heat labile. Pudding, meatball, dried potato are all associated, but remember pudding and meat have been associated. All cases of food poisoning are due to preformed toxin. That is completely wrong. The emetic one is due to preformed toxin. The diarrheal one is not due to preformed toxin. Right? It's almost like teaching microbiology. Enterotoxic pathogens. When you look at enterotoxic pathogens, Vibrio cholerae and ETC. Most important, ETC is the one that is classically associated. No invasion of mucosal surface, perfectly right. Intestinal fluid loss due to toxin, yes. Increasing cyclic AMP. Watery voluminous, correct. Chance for dehydration is there. That's why whenever you are having dehydration, you think of cholera. Blood, the mucous abdominal plain sepsis, nothing is there. Blood is not there, mucus is not there, frequent stools are not there, denismus is not there, nothing is there. That is the point of knowing anatomy properly. If you know anatomy properly in any subject for that matter, your job is half done, because the essence of medicine itself is to place the disease in a pocket. We talk about the word localization a lot with respect to medicine and neurology, but I think localization is the word to use not just in neurology. It's the word to be used everywhere you go in medicine, because the more you can localize and place it in a pocket, rest of the things you can very easily decipher. Okay, endotoxin mediated activation of adenyl cyclase is perfect. That is what is done by ETC and Vibrio cholerae. Vibrio cholerae dash mediates attachment of Vibrio to the intestinal mucosa. That is called as the toxin co-regulated pilus, TRP. Inflammatory cells are absent in stool, perfect, because it's small intestine. It produces hypokalemia and acidosis. That is the reason why we prefer ringer lactate. Okay, we prefer ringer lactate in these patients, and that is the reason why we are losing potassium, we are losing bicarbonate. So that's why it's called as hypokalemia acidosis. Which is actually equal to normal anion gap metabolic acidosis. We'll study in detail later on when we study hypokalemia, how to differentiate and all that. Drug of choice for cholera, I need not tell you, is doxycycline and azithromycin in brackets. Done. Yes, identified. Acute diarrheal disease after eating raw fish with hemolysis, Kanagawa phenomenon, and no role for antibiotics. This is classically what we call as Vibrio parahemolyticus. This is Vibrio parahemolyticus. Okay, this is an infection module, but extreme high yield for the exams. Because it's extreme high yield for the exam, you have to be known this. And when you study like this with a clinical correlation, it becomes very easy. ETC has a heat labile toxin which acts by increasing cyclic AMP. This is what I told you. It also has a heat stable toxin which acts by increasing cyclic GMP. But that's not important for this. This is more important. Most common cause of travelers diarrhea, community acquired diarrhea, everything, the answer is ETC. EHEC, very important, can produce dash with hemolytic anemia and thrombocytopenia. That is HUS. So when you think of HUS, childhood HUS is produced by 3 organisms. Most common is enterohemorrhagic E. coli O157H7. This is producing what toxin? Shiga-like toxin or SLT, which is also called as verocytotoxin. Second most common organism is Shigella dysentery. Shigella dysentery produces what? Shiga toxin ST, and this to account for 90% cases of childhood HUS. 10% cases of childhood HUS is due to Streptococcus pneumoniae. And what does Streptococcus pneumoniae produce? It produces neuraminidase toxin. So neuraminidase toxin produced by Streptococcus pneumoniae, and the other two are actually producing these toxins. Okay, so I think all these questions are very, very clear. So enterohemorrhagic E. coli is different, enteroaggregative E. coli, enteroinvasive E. coli, all that you know. But what is important for the exam is enterotoxinic E. coli and enteroinvasive E. coli. Okay, small volume bloody diarrhea, abdominal cramps, fecal leukocytes is all equal to invasive diarrhea, which is basically seen with large intestinal organisms, which include Shigella, Salmonella. Once again, repeat is NTS, non-typhoid salmonella, not typhoid, Yersinia enterocolitis combination, Campylobacter we have seen, Enterococcus histolytica we have seen. So, stool with inflammatory X-ray containing neutrophil mucus and blood, what is there? It is invasive. 100% invasive. The best answer is shigellosis. And does Shigella produce any toxin? Yes, Shigella produces toxin, but the toxin actually produces a mild kind of increase in cyclic AMP and mild secretion of fluid. So it's like produces diarrhea. Shigella-like toxin is cytotoxic, but both these toxins are not responsible for the disease proper. Disease proper is due to invasion by plasmodium. That's what I'm trying to tell you. Toxin is not important here. Invasive diarrhea versus IBD, how to differentiate? We have seen in the previous module. What you have to look for are two very, very important things. First thing is that look for lactoferrin and calprotectin. If lactoferrin and calprotectin are there in stool, it is very much indicative of IBD. Second thing that you have to look for is with respect to extraintestinal findings, which are correlating with disease activity in IBD. And the extraintestinal findings correlating with disease activity in IBD are erythema nodosum, episcleritis, and type 1 peripheral arthritis. Okay, type 1 peripheral arthritis. This we've already seen. Shigella enterotoxin produces increase in cyclic AMP and all that, but it's not of value. How it produces the disease is by a completely different mechanics. Completely different mechanics. Okay, now recommended therapy for shigellosis. Again, ciprofloxacin is considered with a drug of choice, but don't worry, you can give azithromycin to these patients. There is no harm in giving azithromycin to these patients. Okay, we generally give azithromycin, but textbook wise, the best results for shigellosis have been with ciprofloxacin. Non-typhoid salmonellosis, again, invasive. Area. Most dreaded complication is iotitis or iotoarthritis. Okay, iotitis bar endovascular infection. So iotoarthritis bar endovascular infection. Diarrhea is seen in dash week of entry fever. Generally, we don't see diarrhea now. Diarrhea and entry fever is an odd man out kind of thing. So generally seen in second week if you're asked for the exam, but not important. Dash is the commonest complication is perforation, which can be seen in the third week. But I'm not discussing typhoid right now because typhoid not to be complicated, not to be confused with diarrhea. When you talk of diarrhea in salmonella, it is not typhoid, it is non-typhoid salmonellosis. It is NTS that you're actually talking about. Okay, right, and just to show you the raw spots which you can actually see in typhoid and ideal perforation that you can see in typhoid, especially with Peyer's patch hypertrophy and all that. But remember that it is non-typhoid salmonellosis that we are talking of. So this table is again trying to tell you the differences between salmonella, shigella, campylobacter, etc. But in general, we have discussed everything. Salmonella is something which we are talking of right now with respect to non-typhoid salmonellosis and not the routine salmonella. So we are not actually going to talk of this. Peak oral is how you get most of these things. So there's nothing much to discuss. Incubation period is generally 1 to 3 days is what we see. Pathogenesis is invasion. All the toxin is there, it is still invasion. And bacteremia is generally very uncommon. It's not common to see any bacteremia as such. And you can get complications depending on the individual disease, which again, you've been taught in microbiology and important things I will also highlight on. If you talk of salmonellosis, the most important thing that comes to mind is iotoarthritis. Shigella, when you think of, you can get HUS per se, you can get seizure sometimes, but that's all very uncommon. Campylobacter, exactly what happens, like I told you. So that's why in microbiology, when you have these organisms and different tables, please don't get foxed by that because those things we can actually speaking study. Toxic megacolon, very important, I told you, associated with ulcerative colitis. Invasive large bowel diarrhea, can you get toxic megacolon? It's not that common. Incubation period questions are very, very easy to study. 1 to 6 hours, you have staph and Bacillus cereus, heat stable toxin. 8 to 16 hours, heat labile toxin of Bacillus cereus as well as Clostridium perfringens. Almost everything else is more than 16 hours. Most of the bacteria we study are 1 to 3 days. Only thing to remember is inside 6 hours, staph aureus and Bacillus cereus, heat stable, and heat labile toxin. Maxillary serious clostridioides perfringens is 6 or 8 to 16 hours maximum. So finally, this is what it is. Causative organism for HUS, best answer is enterohemorrhagic E. coli. Reactive arthritis is equal to chlamydia trachomatis worldwide, but in India it is Shigella flexneri. So India is Shigella flexneri. Bone marrow suppression that you actually see is with typhoid. Guillain-Barré syndrome you see is with Campylobacter jejuni. Okay, toxic megacolon that you generally associate.
Yes, person.
Change going on level. Eh? Okay, now. Preparation started. Okay.
Thank you.
So ulcerative colitis with infection to get toxic megacolon is very, very unlikely. But in case you are asked, then you can again say invasive organisms, any invasive organisms. Aortitis, endovascular infection is non-typhoid salmonellosis. Intestinal hemorrhage is again something that you associate with typhoid. Right lower quadrant tenderness is something that you associate with erythema. Small bowel lymphoproliferative disorder, immunoproliferative small intestinal disease is associated with Campylobacter jejuni. Fine. So this is how the whole thing goes. I think it's very, very clear. So I'm not mixing up typhoid so much because typhoid as such is a small intestinal invasive disease. Okay, and their diarrhea is not common. And if you think of invasive diseases, anything with respect to invasive disease, think of Shigella, think of non-typhoid salmonella, and think of Campylobacter. In this whole module, what is most important is I think something which I have not told you.